Hello, good afternoon. Let's start. So we are starting right now the symposium of Johnson & Johnson. During this symposium, we use some voting. So you have here the application of the Congress. If you look at the application, you see here, this icon, it is a hand. So you have to go in this icon in order to be able to vote. Okay? So it's very easy. Application of the Congress. When you open the application, you have these icons here. This last one, that is like a hand, it is the place to vote. So it's just touch, and you will have access to the application to vote. Okay? So, the right procedure for the right patient at the right time. So thank you for coming, for joining us in this symposium. Thanks for Johnson & Johnson for the continued education system they have. We will have 4 presenters here in order to showcases to you. Let me invite them to join us here. Ronald Lien, please, from Netherlands.
Give it to me.
Torsten Nobers from Sweden. Bruno Dillemans from Belgium. And Mohit Bhandari from India. So they will present cases. We will discuss the cases. We will vote. Let's see if you agree with the decisions they had about the cases.
No, thank you.
So, Dr. Lien is a bariatric surgeon in Dutch Obesity Clinic, president of the Dutch Society for Metabolic and Bariatric Surgery, head of the Department of Surgery of Groningen Heart Hospital, board member of the Dutch Audit for Treatment of Obesity, and you can see here his case mix procedures. I'm impressed. The numbers here, 68% gastric bypass. Okay. Professor Torsten Nobers, professor of metabolic surgery at the Institute for Clinical and Experimental Medicine, Wallenberg Center for Molecular Medicine, University of Linköping, the Department of Surgery, Vrinnevi Hospital, principal investigator for the nationwide Swedish program for adolescent bariatric surgery, AMOS study since 2006, also 70% of gastric bypass. How much for you, Bruno?
Around 70, 75.
75.
Bypasses. Yeah.
Dr. Bruno Dillemans from Bruges, directing the Center of Obesity Surgery in the AZ St. John Hospital in Bruges. Large experience in bariatric metabolic surgery, large experience in revisional, more than 17,000 procedures, surgery from all over the world, and visiting him for courses, for training in Belgium, in Bruges. His Center of Obesity Surgery has become a center of reference for revision in bariatric surgery for patients coming from the different continents. So the patients you have are coming from what place?
Not from one place.
Active IFSO member and joined the global J&J Advisory Board in Revisional Bariatric Metabolic Surgery. Dr. Mohit Bhandari from India, Indore, bariatric metabolic and robotic surgeon, founder of and director of the Mohak Bariatric and Robotics, a big center of training in bariatric, metabolic, endoscopic, robotic, every kind of procedure that we can do to treat bariatric and metabolic disease. Dr. Mohit Bhandari, it is an expert. Director of the Bhandari Group, clinical professor, medical school department of surgery, and director, performing the highest number of bariatric procedures in Asia Pacific region, to more than 12,000 procedures, pioneer in robotic, pioneer in endoscopic, and endoluminal surgery. So you can see that the 4 surgeons we have here are very, very expert in different issues in bariatric and metabolic surgery. So let's start, test your voting. The first question, please open your application. Let's see. Let's have a better idea about your practice.
Never.
So how long have you been working as a bariatric surgeon? Ute? Ute? They are controlling there? Okay? So the computer is there, no? So how long have you been working as a bariatric surgeon? A, 1 to 5 years, B, 6 to 10, C, 11 to 15, D, 16 to 20, and E, more than 20. You can vote now. Let's give a couple of seconds to you to vote. So for that ones that you arrived a little later, just open the application of the Congress. In the application, you have different icons. So the last one that is like a hand, it is the icon for voting. Just press that, and it will be very easy. Can we check the result of this voting? So this first voting is about how long have you been working, and you can see the majority, 31.5%, 31.5, 1 to 5 years. 6 to 10, 21 to 5. And 11 to 15, 22. 16 to 20, 16. So we have a group of very experimented surgeons here also. So we have good guys here, good guys there. I think we have a very good discussion. How many bariatric and metabolic procedures are you performing per year? So let's see, A, less than 100, B, 101 to 200, C, 201 to 350, D, 351 to 500, E, 500 to 1,000, and F, more than 1,000. Please vote now. Let's see the grade of experience you have, how many cases in average are you doing per year? How many cases per year are you doing, Bruno?
1,500 now.
Mohit?
Yeah, around 1,200 to 1,500.
Torsten?
Something 400.
400? Ronald?
300.
300? And this is just you, or counting
team.
with all the team?
Yes, yeah.
All the team?
Just me.
Just you. Mohit, how many surgeons are working with you?
How many?
Surgeons
Surgeons?
in your team?
3 to 4.
3 to 4. So let's check the result, please. Can we check the answer? How many bariatric procedures have you done? Are you doing per year? Less than 100, 40%.
More than
That is
1,000,
the major number. 101 to 226, 201 to 350. So in general, the centers of excellence, they consider that the surgeons should do at least 50 procedures a year to be involved in an excellence program of bariatric and metabolic surgery. Can have some variation, but in general, it is around 50. Let's go to the next one. Which one of the following procedures do you perform most often as primary procedure? So, what procedure do you prefer? Gastric bypass, sleeve gastrectomy, OHB, SADIS, or other? Other may be endoscopic procedure, maybe duodenal switch, maybe biliopancreatic diversion. Is something different than A, B, C, and D. You can vote now. Which of the following procedures do you perform most often as primary procedure. So we have here gastric bypass with Dr. Ronald, Dr. Torsten also gastric bypass, Bruno also, Mohit.
I would do all three equally. We have an algorithm, we don't do
But
one.
what do you do more? In numbers in the end of the year, what do you have done more?
I think more would be bypasses.
Gastric or one anastomosis?
One anastomosis.
One anastomosis gastric bypass. So let's see the result, please. Gastric, more is sleeve gastrectomy.
Sleeve.
47. So it's not the international numbers, but it's pretty close, because what we have more, it is sleeve with almost 50%. If we go for IFSO literature or ASMBS literature, we will have more than 60. Here we have 50. So we have a group that is doing less sleeve gastrectomy than the average. 10% OAGB, Mohit.
Yeah, I think this number is going to increase. I'm very positive about it.
So, are you doing OAGB, Bruno?
Yeah, very rarely. Patients older than 50 years old and very obese, and BMI more than 45, then I would consider to do that. But they have to have passed the age of 50, because I'm still a bit concerned about the potential oncologic effect on the longer term. So I just try to find it for all the patients.
Considering, Dr. Torsten, that when we talk about OAGB, the first question it is regarding alkaline reflux. Do you think that this procedure has any recommendation for young and adolescents?
No, I would say that this should be considered experimental for young people, as the longevity of it hasn't been tested enough. I think we shouldn't explore new procedures within the youngest population. That's my opinion. So I wouldn't suggest OAGB for adolescents.
Dr. Ronald, your feeling about one anastomosis gastric bypass?
I think part of the procedure has some specific entities that could be useful in a gastric bypass, so I would rather have the good things of the mini bypass in the gastric bypass, but I'm not very much in favor of the single anastomosis gastric bypass.
Okay, great. Let's move for the next one. How much % of your total practice are revisional surgery, considering revisions, conversions, and corrections? A, less than 10%, B, 10 to 25, C, 26 to 50, D, 51 to 75, and E, more than 75. So the question is, how much revisional surgery are you doing? You can vote now. How much revision do you have, Dr. Ronald?
In my practice, it's around 10%.
10? Torsten?
I have a fairly high in different settings, but it's relatively high, 20% revision.
Bruno?
25-30 now, actually.
Yeah, around 20%. Yeah.
So one of the issues I like in bariatric surgery, Bruno, is that I can schedule 5 or 6 procedures. Roentgen gastric bypass, primary procedure, I know that I will start at 12 and will finish at 8. But if I put any revisional procedure, I don't know when I will finish. So how are you managing this? Because you are starting something that you really don't know when we'll finish.
What we try to do is we give codes to the patient and the difficulty that we expect. So we have code 1 for a standard bypass or a sleeve, code 2 for a more complex, a band to a bypass or some not so difficult revision, and code 3, a more substantial one, revision of a BPD or whatever, and then code 4, you know, those patients who have got extensive. So we have time limits for sure, but we are more coding, we are more booking our patients based on the code than the number of the patients.
Yeah. Can we have the answer? Another issue regarding this, Bruno, is that besides to see the procedures that will consume more time for doing, probably is the procedure that you have more complications. That means that that patient will stay longer at the hospital. So as the same, for us, that's not good, no? Because it's not so predictable. So numbers of revisional surgery, less than 10%. The majority is with less than 10%, 65%, 10 to 25, 30%, and the other numbers really are less. It's not so frequent. Ronald, do you want to present your case?
Yes, certainly. I was asked to present a complex adult case, and that starts simple and then it becomes complex. So I need your input for this. It's an actual case, so I didn't make it up. It's one of our patients. It's a female, 1990, Caucasian, BMI 46, with a history of infertility, hypertension, reflux, mild CPD, and lab cholecystectomy in the history. She's on PPI, hypertension medication, and some mild inhalation medications, and she's smoking. So, what should you advise to this patient?
Can we come back in the previous slide, please? So female, 46 BMI, infertility, hypertension, reflux. Let's discuss a little more the reflux. What kind of reflux is this?
She's on PPI, so she has her stomach content into her throat.
And at this moment, do you have endoscopy?
No,
No endoscopy.
it's a simple case.
Okay, we can move. So based on your option, choose one of the options. We can vote now. What is the history of the obesity treatment of this patient, Ronald? What she has done in terms of treatment of obesity?
She was on a diet with a dietitian, had some weight loss but not sustainable, so she regained, and her infertility was her main reason to find a cure for obesity because she wants to have children.
Okay. Can we see the results, please?
Very good.
You could see that the majority agree with you, no? Roux-en-Y gastric bypass.
Yeah, I'm in favor of gastric bypass, but that's not what this lady had. She had a sleeve gastrectomy. And she had a sleeve gastrectomy because she was very afraid of the possibility of an internal herniation during her pregnancy afterwards. So that's what she insisted on, having a sleeve gastrectomy instead of a gastric bypass. So, unlucky for us, it was not uneventful because she, a couple of months after the operation, she returned to the clinic with abdominal complaints, and after diagnostics, she had a late proximal leak near the junction, and we asked our endoscopist to treat it, and he did first an endoscopic clipping of the fistula, and that didn't work out, and then we tried a Botox treatment of the pylorus once, and that also didn't work out. So, how should we proceed?
So can you precise a bit more how long after the procedure was?
5 months. 5 months after the primary procedure. So the first 5 months were uneventful, and she presented herself 5 months after the primary procedure with abdominal complaints.
And in the previous 4 months after the procedure, the patient was good?
Yeah.
No complication, nothing?
No, nothing.
So following in the case, you could see that is a patient that had a sleeve gastrectomy with a leak 4 to 5 months after the procedure that has done different intents for closing the leak using endoscopic approach with no success. Okay?
No
That's
sutures,
correct?
just clipping, yes.
And the condition of the patient is good. Is eating.
Yeah, she had proper
No
weight loss
fever,
in the
no
beginning.
abscess.
No, not initially, no.
Can we have any information from endoscopy or upper GI, about
was
some torsion, some stenosis of the sleeve?
No,
it's
it
perfect.
was just a regular sleeve with an evident fistula just behind the junction, very proximal.
Let's vote. Let's see what do you think about the case. No further treatment, 25%. Revision, 17. Correction, 11. Conversion, 46. Conversion to what?
We converted to a room-wide gastric bypass with the thought that we would convert a high-pressure system into a low-pressure system, and that would hopefully solve the fistula. At first, it was uneventful again. This was the revisional surgery. But then she returned again after a couple of months with persisting inflammation in the left upper quadrant, and there was an abscess now.
So if you look to the picture, where is the leak?
So this is the pouch.
Uh-huh.
So we cut the sleeve, I think approximately 5 centimeters below the diaphragm, and what was an uneventful anastomosis. This is the spleen.
Did you try to close the hole? Did you try to close the leak?
No, that was one of the difficulties. This is the left liver lobe and the spleen and the pouch, and this was very, very adherent, so it was very aggressive. Okay. So we thought rather not break it down with the risk that we had to do an acute esophagus anastomosis. So we thought in a safe zone we do the anastomosis, and then hopefully the lowering of the pressure in the system will solve the problem for us.
Were you at any point considering going for esophagus?
No, not yet. This was our first step, first option.
So I think the majority of the surgeons, Ronald, for a case like this, would prefer to derivate the leak, the fistula itself. Why you don't like this kind of approach?
Maybe because we do not see very much sleeve leaks, so we try to be on the safe side, and breaking down that proximal area would have a big risk in itself to do an anastomosis on the esophagus immediately. So we try to avoid that. When she came back, she had on CT scan an evident abscess, and it was drained percutaneously. And I also did a blue dye test, and that came out negative a couple of times. So we converted to room-wide bypass. Probably the fistula is still in place behind the adhesions, behind the left liver lobe. And now she is having inflammation and a percutaneous drainage of the abscess. But it doesn't solve the problem at the moment. So the inflammation is not solved by the percutaneous drainage.
How do you proceed? Nothing, and different options of revisional surgery. You can choose now. Let's see, how do you think? It's really a complicated case, huh? It's not easy.
I think better drainage.
So when you did the conversion to bypass, you just cut the stomach, did the pouch, and that's it.
Uneventful, easy. Wasn't actually an easy operation, so.
Let's see the result. The majority thinking about not doing any further procedure. Revision 15, correction 15, conversion 9. Did you have any case like this?
Yeah.
What have you done?
Oh, the same thing converted into a gastric bypass most times.
But if the leak continue. If you continue having leak, what's next?
So the next procedure would be to put a mega stent again in the same bypass. And that is going to heal in a much better way than it heals in a sleeve, because that's a low pressure zone and you further convert it. The only problem you can have is a stent migration. So you need a long stent.
Bruno.
Just had one case with a persisting fistula after long trying to get it drained, and then at the end we had to do an esophagojejunostomy. So we had to go higher. And then it healed quite nicely. But we had to go quite well into the chest, 3 or 4 centimeters above the Z line to get away from the inflammation to a more or less virgin wall of your esophagus, and then it healed. But it's very rare that it is not healing because you have that low pressure zone. So I really think that you have to, try to persist in getting a good drainage. And then that was also your assumption, I think, that by just drain it, it could heal. And then very rarely, it's not healing.
Exactly.
We had just one case as such.
The problem in such case of going high up into the esophagus is mediastinitis. So I would not try and do that unless we are unsuccessful with the stent. If we are able to take care of the stent and proper feeding jejunostomy is fine. If it does not heal at that 4 weeks from then, we can go up and take that risk of mediastinitis.
Please, if you have any suggestion, just raise your hand and we can put a microphone, okay?
So last April, we decided, because the percutaneous drainage did not work out, we would go for a surgical solution and drain the abscess retrosplenically by laparoscopy. When we were able to split the spleen from the diaphragm, and we found an abscess. So we thought, well, we solved the problem. So I drained it, and after a month or so, drainage was completely to zero. CT scan was without any rest abscesses, and lab results were fine, no inflammation in the blood, so I thought we solved the problem.
So the problem was not a persistent leak, it was just an abscess.
Maybe. We're not done yet, tell me no. But then I made a swallow study after that operation in April, and I saw again a leak. So I went back just before Madrid and drained it again, and I found another collection even further up behind the spleen, almost at the angle in the first picture. And I put a drain there again, and now I did another blue dye test, and it is positive. So now there is a connection between the fistula and my surgical drain. And actually my question now is, what should I do when I get back from Madrid?
I mean, she's a young patient, I can see 1990. I mean, I'd try back again to be conservative and hope for better. Is it now not the moment to try to have a stent somewhere, I mean, I'm also not a fan of stents, but,
Even after so
if you look
long?
at the results, I mean, it does something anyway, I mean, in that stage, after so much failures, if I may say, I think there's a player to consider to put a stent.
I just wanted to know about which stent you use in sleeve leaks, because I think that's the variable. I've seen people putting variable stents, some of the gastroenterologists putting short stents. I think the longest possible stent is the best in such circumstances.
Sure, and you don't have a pylori, so it's not easy. We all
It's not
know
easy,
that
it can
after
migrate
bypass
there,
it's not fixed well. I mean, a lot of those, going to migrate anyway. But at the end, I hope not going to be the case that you have to go higher, but then you still have to wait further 3 months, that at least, you have a more or less acceptable entrance and dissection field. Otherwise, you cannot do anything still now, I think.
The clinical condition of the patient is good?
It's good.
Yeah, it's good.
Yeah. All arguments to wait to jump on that in the theater again, I think.
Just a comment that the problem, I think, which is playing a part in this situation is that you purposely did a longer bigger pouch than a normal room-wide gastric bypass.
Slightly longer, yes.
Yeah. So what you will face now is a situation where you have a relatively high output of gastric juices, increasing or decreasing the chance of having a healing of the fistula. So I would guess that this will end up in esophageal gynostomy, but maybe with a long time with parenteral nutrition in order to make her as safe as possible when doing that.
But we don't have any estimate of what is the magnitude of the fistula at this stage. Where is it just actually, etc. That you don't have any endoscopic.
She is scheduled for an endoscopy after the weekend, and then
after IFSO.
After IFSO, yes.
It's going to be good.
One more vote?
Additional procedure, yes or no, revision, correction, or convection. You can vote.
So the take-home...
How many times in this period this patient has done an endoscopy?
2 times.
2 times.
First, the clipping that failed, and then one more time, and then the fistula was still in place. So,
what is right now, what can be the endoscopic picture of this patient? We can see a leak by endoscopy?
yes, just a little fistula.
And gastrojejunostomy, how big it is?
It's regular size. It's, I think, 2 centimeters or so. And feeding is not a problem. So she was always able to have her meals very easily. And now I put her on parenteral feeding just to give it a rest while I'm here.
This is the kind of leak that can fistulate to the thorax, to the bronchial. It is a chronic one and continue. So let's see the result. Zero, 0, nothing.
It's a difficult case.
Nothing to do.
So I was thinking before I came to Madrid, what's my next step? I thought maybe try one more endoscopic closure, but maybe try to overstitch it, because that's what we not did 1 year ago. Maybe pigtail drainage, inside out, outside in, instead of a surgical drain that's now in place. So replace the surgical drain for a pigtail intraluminally. And the final solution, or the last resort solution, should be resection of the pouch.
So in the end, the solution was endoscopic. The solution was endoscopic in the end?
No, the first two endoscopically, and then the last resort solution to the problem is what Bruno suggests. That's a major resection.
Esophagogynostomy.
Yeah.
But isn't it a weighing about the short-term safety of the patient compared to the long-term? She should live 60 years with whatever she ends up with.
Yes.
So this is also a perspective that the next operation needs to be an operation that puts her on safe ground. Yeah. So it's, but then weighing that to the short-term safety.
You have to let us. You have to inform us afterwards for IFSO in Miami, I think. Give us feedback, you know. But I hope that then the story will be.
I'll enter the video for the website.
Yeah. Good. Yeah. Thank you.
Okay.
Okay. Thank you.
Okay.
Thank you so much. Dr. Thorsten, the complex adolescent case. So before we start, let me ask you something. We just was discussing a consensus about indication of the surgery, and we had some doubt about what to consider a child, an adolescent, or a young adult. Is there any classification that we can use?
Unfortunately, this classification isn't clear because adolescent could be referred to either as under 18 or under 21. Normally, I refer to adolescents as being under 18, but in much of the lots of the classification is under 21, and I think we need to find the wording that is right. That we actually understand what groups of patients we are talking about. I think that one classification is post-pubertal youth, adolescents, and then you have child.
Okay.
That is below that, but it's not entirely clear. Should I? Good. Let's see for the next. So, it was 4 years ago, actually, I met this girl that at that point was 15 and a half years old. She had a weight of 117 kilograms with a BMI of 41. It was noted when she was sent in from her pediatrician at the county hospital that she had a relatively poor compliance to conservative treatment. She was not coming to the visits, and she was gaining weight continuously. She has been under their radar for a number of years. She had a limited social support, which was one of the reasons for her limited compliance. She had a single mother and a sister, but not the full support, so to say. She had frequently absence from school. On the medical side, you can see that she had a very central obesity. She had the male-ish kind of body. She had severe hirsutism with really hairy chest that could belong to a man. She had troubles with urine, so she was bedwetting, and she had incontinencia also. So that was something also preventing her from going to school. And she had blood glucoses running in the pre-diabetes range. So that was a bit of what I saw at that time.
Good.
So the next is a question mark. What do we do?
So the question is how to proceed. Let's come back here.
Yeah, you can go.
So
How to proceed.
we can use that questionnaire to vote. Here. So what should we do with this patient? No surgical procedure. You should recommend a sleeve, gastric bypass, one anastomosis, gastric bypass, SADIS, BPD, or other procedure. Any other suggestion here, Torsten?
No.
So you can vote now. If you have any question about the case, just do it. A young lady, 41 BMI, prediabetes, with some psychological problem. What is the option? This patient, Dr. Torsten, it is cleared for a multidisciplinary group, for a multidisciplinary team for surgery?
Exactly. She was at the center we had. She was assessed, and these were the outcomes of the assessment. That this was the situation, and there was no scope of improving anything. From things were like they were.
Okay. Let's check the vote. It's not working.
Let's do raise of hands. Could we do instead, maybe? Okay. Oh, we have it now. Okay.
Well, that's a pre.
So this is the result. Is the last one? It's the same, no? It's not working. Let's go back to the case.
Almina, might we have a raise of hands instead?
Yes.
That might be.
Let's do that. which is your experience with adolescents?
Quite an experience of, I think, more than 100 patients. But in that particular case, 15.5 years. Compliance, big question mark. I certainly would postpone a surgical treatment at this stage. That's my personal opinion. And try to enhance, to improve the compliance of the patient for also afterwards.
And do you think, Bruno, that as we are leading with a young lady, an adolescent, that's enough a reason to go straight for a sleeve gastrectomy with the idea to use something less invasive, or you don't like that?
I would definitely go for sleeve in that particular case. If I would decide to go for a surgical procedure, 4 or 5 years ago I would go for gastric bypass. But you know, she's a young lady, we know the internal hernias, although you try to close it very well. I mean, probably going to become pregnant, so I am a bit more, you know, reluctant to go for bypass in that particular case. But anyway, I still, she's a bit too young, you know. She has to you know, show a bit more compliance and dedication and discipline, I think, before you can go ahead.
Could I just have a question to you, Bruno? In your, just now we are stressing your point that you want to wait. And what do you expect to be better?
I mean, you know, that's a multidisciplinary approach anyway. The parents have to be there, etc. I mean, you know, 15, she's really young, you know. I mean, it's not between the 16 and probably you took a picture of the left wrist that she's probably already, you know, full grown. That's the minimum that you certainly have to check, I think. But if that's the case, you know, you have to wait a bit, you know. Single mother, I can see, you know, one sister. Try to have a bit better comfort, I think. Yeah.
But a little bit, again, the question: what do you think is gonna be better, and what are the chances of things getting worse? That's a little bit of the question.
That's right. I mean, that's always the question, you know. But you know, with a big targeted multidisciplinary team, we can hope that in a way the results for surgery that you can postpone 6 months or even a year, you know, that we're going to have better results. That's also a bit the literature is at least advising. You're 100% right. It still will be influenced by the individual commitment of the patient at the end of the story. But
I just want to challenge that the influence of the willpower of the patient, that this is central. This is a little bit what I'm challenging here. That because we are so often putting the willpower of the patient in the center, that they have to have a strong so to say, they have to grow in commitment to what we are doing.
Yeah,
so let's see if we have any comment or any question here. We have one microphone in each side, so okay, let's see. Okay.
You operate her immediately?
Yeah, please.
So, patient must have been assessed by endocrinologist.
If she was assessed by others, sorry.
This patient was assessed by endocrinologist?
Yeah, and I can fast forward a bit and say that she was assessed by everybody in the pediatric team, including psychologists and everything, and we agreed that she should undergo surgery. So this is where we ruled
out some like congenital enzyme deficiency and all that, genetic things and all that, right?
Yes, she had all the assessment from there. She was just a, so to say, regular, metabolically ill, severely obese adolescent.
Omino?
Microphone here. Okay. Just a minute. No? It's not working? Go ahead, go ahead.
Well, I had the same experience that you were saying, because in Brazil, in the pediatric surgery unit, Professor, we had children with BMIs as
Deu
high...
velho.
Como?
Deu velho, no?
No, velhote? No.
Velhote.
No? Maxud, Professor Gilberto Maxud, the chief of the pediatrician surgery, he called us. They had children with BMI of 80 and 70, and they were at their 15, 14. So they wanted a potent procedure, but they didn't want any kind of exclusion, and they didn't want any malabsorption. The first 10 cases of sleeve gastrectomy with transit bipartition were done in adolescents in the University of São Paulo in a case exactly like this. In my opinion, I know it's exotic by now, maybe it will be not exotic in the future. I would do a sleeve gastrectomy with the stomach drained into the ileum with total access to the duodenum, because she can take medicines, she will have good nutrition.
We know that you are not doing you are not doing something with the intent to create malabsorption. No. But malabsorption can occur in some cases like this.
Well, we learned how to manage this now. We very much extended the common channel because it's very clear to us that malabsorption is just a marker of a good procedure, but it's not needed for a good procedure. So that's why we think that SADI is so much better than a common DS. With a bipartition, with a very high, a very long common channel, malabsorption is close to known. And this child will have the opportunity to grow, to take medicines, especially because she has psychiatric problems also. So I think, and she will have endoscopic access to everything, which once we expect her to live at least more 60 years.
Can I say something? Almeno, no? I love Sergio Santoro. For me, he's really a great mind, a bright mind. But I would discourage you by using this operation in an adolescence. Strongly discourage. First of all, because if this happens at least in my country, you have a minimal complication, you go in jail.
Oh. That's a good reason.
Very good.
It's a good reason.
It's a good reason. And this is first. I can't wait. Second point, I think is in the experience of most of us that are doing for the last 20 years this kind of surgery, it is very, very possible that this patient is going to have an operation that is going to be revised. If we talk of banding, a percentage of revision will be 50%. If we talk of sleeve, percentage of revision may be 20%, but still. And if we talk of gastric bypass, this is percentage of revision at 10-15 years. So I think that we should consider in perspective that this young patient might have in the natural history of the disease, that is obesity, control of the disease for the last 40-50 years. So for me, doing restriction by banding or sleeve, certainly the preferred things. And afterward, because we must think the progress of the disease.
So Luigi, before going to Sergio, what should be your option for this patient? What is your first choice?
Well, I can tell you that certainly sleeve gastrectomy for me is the best operation for this kind of patient, but I would consider also banding if the relative of this patient, because you need to put the operation not only in the patient, but in the family, because the young lady is living in a family where you may have relatives that are very worried and afraid of resection, of major surgery. So I would be open to this too.
First option for you is sleeve or band. Okay, let's see Sergio. After that, we can talk with you. Okay, just Sergio to respond to Luigi.
I would never put a band. And I have recognized that the sleeve would be the step, but the fact is from a bipartition to be back to a sleeve, it takes 15 minutes. So it's a very simple procedure to be back to a sleeve. It's the easiest procedure to revise, but a sleeve is very little. We have applied the sleeves in children, and there is weight regain.
Luigi, let's see that way.
Pigs. These are not pigs, are girls. She's again, when you enter in the bowel of you manipulate the bowel,
I suggest you I suggest you and I can go with you. Let's go to the bar after the meeting. We can ask for a beer and have this discussion. That side here, please. Ayed.
Thank you. This case, we should understand from this scenario, all her problems are related to obesity, hirsutism, enuresis, even psychological problem, even absence from school is because of her self-image and her obesity. I will offer her sleeve gastrectomy. And there is a concern Dr. Delman mentioned about growth and X-ray. We have proven by studies that they grow better if you do surgery in the early age. So there should be no concern about affecting their growth. So definitely this patient, I will offer her sleeve and with a good follow-up.
So Ayed, just to have clear, that is for this case or first option for child and adolescent is always sleeve?
Well, we have started banding, bypass, but now I think the best option currently that will give maybe up to 5 years, and we have 10 years follow-up on patient, more than 2,000 patients with sleeve gastrectomy in children and adolescents. They have excellent outcome, up to 70% excess weight loss. Some of them reach 58 excess weight loss at 7 to 10 years. So we can give them very good quality of life. We can improve their psychological impact of obesity and absence to school and others by providing this procedure.
And the sleeve you do in a case like this is exactly the same sleeve you do in a regular bariatric patient?
Absolutely the same sleeve, and always my sleeve is restrictive, we don't leave big fundus or big antrum, and that will last in a good period of time.
Okay, let's see the opinion of Dr. Joan Pujol.
Well, we are talking about a girl of 15 years old with a just arriving morbid obesity, and we're proposing surgery. One option is to do a sleeve gastrectomy, which is irreversible for life. The other one is malabsorptive procedures. We don't know if she has already reached enough maturity. We do not have any information about bone maturity. So I think that obesity is true, is a chronic disease, is a serious disease, but it is not an acute disease. So if I'm not wrong and following the guidelines, general guidelines, we should be more strict with this kind of people, and probably I would, instead of discussing which kind of operation to this girl, I would say, well, let's wait 1 or 2 years. Some of them change while they do the genetic change. So why not to wait? There's no comorbidity. So why not to wait for at least 2 years and see what's happening with her?
Joan, to have very clear, which is your option for the patient?
Conservative, wait, and do medical treatment.
We cannot hear her.
Okay. So yeah, I think, Thorsten, you could see that it will be very difficult to have a consensus about this case. What is your opinion? What do you did in this patient?
Unfortunately, it's a little bit hard to hear everything when we're sitting here. It's some kind of echo. But anyway, I heard some pretty strong opinions out there. And I respect that there could be strong opinions. This girl actually was, as I said, she was accepted by the multidisciplinary team. She was included in a randomized study we are currently performing and following up, where she was either to surgery or to conservative treatments for 2 years before having surgery. And she was randomized to surgery. She had a Roux-en-Y gastric bypass, standard Roux-en-Y gastric bypass. It has been from a surgical side and from a kind of, that side has been entirely uneventful. Her mother died 2 years ago, and she is now under care together with her sister, and of course she has even other challenges in life that is there. Her hirsutism went away, most of that. She was not entirely out of bedwetting. She started back in school. Those things happened, and there was not an issue of compliance, so to say, because she she altered the way the operation and changes in signals made her change in terms of obesity and obesity-related issues. I would very much support that we in the community of bariatric surgeons take Lee Kaplan and others on their words and start talking about changes in signals that need to be there in order to change the level of obesity and metabolic diseases, rather than saying restriction and malabsorption, because those are outdated. Those restriction and malabsorption, that's yesterday's language, so to say.
So let's see what kind of progress we did here. For this patient, let's do raise your hand voting now. For this case, how many would continue with clinical treatment, no surgery? How many goes to band, adjustable gastric band? Raise your hand, Luigi. Luigi and Nicola. Sleeve? Gastric bypass? Any more hypoabsorptive procedure, DS or SAGES? Bipartition? Where is Sergio? Okay. You have one vote. Thorsten, thank you very much.
Just if I could have one comment, that I think we need to also take the words of the organizations, that we have to be very, very careful in performing the most aggressive surgeries in young people. BPDs, DS, other things. We should be extremely careful in doing that.
Thank you. Thank you for sharing the case with us. So, Dr. Bruno Dilemas, persistent dysphagia after sleeve and Roux-en-Y gastric bypass.
Thank you.
I'm curious, huh?
Yes, thank you anyway for the nice and too flattering introduction. So my case is a complex revisional case. So it's a bit different. So we're going to try on the part of diagnosis and the part of treatment, looking what is the best solution for that lady that has been transmitted in our unit, I think, some months ago. And this lady has been operated abroad, 50-year-old lady. And she got a bariatric history. She got a sleeve gastrectomy in 2011 with quite well result, BMI 39.8 going down to 25.6. And then for somewhat dubious reasons, I think, not an equivocal reason, there was a bit weight regain, then this operation was being converted to an open gastric bypass. Why open? I'll come to that in a second, because that lady had an Hartmann resection in the past for perforated diverticulitis, and also the reversal of the stoma afterwards. So she had a big, huge incision in front of the belly. And so BMI was 29.6 when they converted to the open bypass, but on the same time, they did a resizing of the sleeve, and so they did some trimming of the gastric pouch on the same time when they converted the patient to an open bypass. Now, after 4 months, there was a gradual dysphagia, initially for solid food, and then at the end also for liquid, for fluids. And then she got abroad then that endoscopic stenting of a bit the narrow gastric pouch that has been diagnosed as such by endoscopic means and also by upper GI serous. And then after the stent removal, there was a bit of marked improvement on contrast study, but then a bit later there was back again the recurrence of the dysphagia symptoms. And back again it has been proposed to do a dilation combined with a stent, but the lady was refusing for that lesser invasive option because she suffered when the stent had been placed. She was just good when it has been removed. Now, the current situation is the lady now got down further in BMI 23.1, and so we are confronted with dysphagia for solid food and also for liquids. So I already mentioned the other surgical history, not unimportant. There was an emergency Hartmann procedure in 2006 and the reversal afterwards. He also got an abdominoplasty and a hysterectomy by open way in 2013. Lab tests were normal. She was taking PPIs 40 milligrams, although she had no reflux. I have to undescribe that, but patients has been taking that medication on a daily basis. And I hope to show you a bit the upper GI symptoms. I think that a contrast study is still a very important tool, you know, the dynamic one, in trying to evaluate a bit how the things are on the functional way, not only anatomically, but also functionally. Can I have the video of that? I'm just going to try to have it. If you can, I cannot click on that. It's the left, and you can see it more dynamically. No. Anyway, what they see, you know, there is a bit dilation of the distal part of the esophagus, and by endoscopy, what you see as well, there's already an epiphrenic diverticulum, which is also a bit a sign that, anyway, functionally spoken, it's not going very well. Those X-rays, those endoscopic images are less relevant. And then I come to the issue, what would you offer that particular patient? What do you think is a problem? And more importantly, what can you offer? Back again, it's mentioned here, further endoscopic dilation, stented. We are a bit hampered by the fact that the patient is really not in favor for that option. But anyway, let's, regardless of that final decision, which is still lying into the patient, what would you offer your patient? No additional treatment, although back again, she's going down in BMI and she's very highly symptomatic, so we have to take that into account. Then further endoscopic dilation, stenting. As a surgical treatment, quite radical esophagojejunostomy, the pouch remodeling, that you're going to try to do something on the pouch, or are there other surgical treatment options? So I just have one poll, one vote. Let's the audience try to vote on that things. I didn't describe the other surgical treatments. We can discuss that after we have the poll.
Bruno, it's a long case. I missed the reason from conversion from sleeve to bypass. What's the reason?
There was moderate weight regain until BMI of 30, and I think that was the reason. There were no complaints at this phase, that's important, between the sleeve and the bypass. It was the weight regain, wherefore the patient opted, and seemingly also the surgeon, to go for the bypass. Okay. And in the meantime, resizing, trimming the pouch, the sleeve.
And manometric study of the esophagus?
That has been done abroad as well, as shown indeed, you know, that at the level of the LES, there was a bit of hypertonic state and a bit lesser motility in the esophagus. But we didn't redo that investigation, but that's true.
So the option to vote is no additional treatment, further endoscopic treatment, surgical treatment, esophagojejunostomy, pouch remodeling, or other. Or if you want to raise your hand, we can send a microphone and you can do your suggestion about what kind of procedure we can offer to this lady. Let's see if the program is working, if the application is working. Try to vote, please.
It's certainly not an evident case, so it's on the treatment option, not unequivocal. And I'm going to certainly ask you, the panelists, you know, what they would offer that particular patient after the voting.
Let's check the voting.
Bruno, just a question. Did you have an ability to perform some kind of manometry?
Yeah, the manometry has been done abroad.
Okay.
So
sorry, I don't hear it.
Yes, the sound is not good there. There's a bit hypertonic state at the LAS, and a bit dilation, etc., and a bit less motility in the esophagus, probably because of the dilation.
There is 12% of you voted in some other procedure. What is some other procedure?
Yeah,
Tell us, please.
How many attempts did you undertake to dilate the anastomosis?
One attempt, because she was more or less refusing a second one.
Okay, other procedure, what is?
Myotomy can be thought of?
Myotomy?
I mean, she has LES hypertonic, the esophageal dilatation, and the scope is going through, right?
Who is saying that?
Me.
Stand, please. Stand, please, so Bruno can see
We're going to give a little applause for that guy, because that's indeed what we did. I'm going to show you on the video. I mean, he was just before you. I mean, I think that esophageal jejunostomy, you see that the thinking process, the decision-making process is not unimportant, you know. Some surgeons would go for an esophageal jejunostomy, which is a really invasive procedure. What we did, I can hope to show that on the video. Can we have the video running? There were quite a lot of adhesions. Back again, open laparotomy, etc. But what we did an extended myotomy of the complete sleeve, and we even included a bit of the gastric jejunostomy. And we went relatively high into the chest, because you have seen that epiphrenic divertical, so don't stop too early. We went relatively high. And I'm just going to show the video. It's 3 minutes or something. And that this patient is doing really fairly well. So this dysphagia has stopped. You know, she's eating now very properly. BMI is going up a bit. She has, back again, a very great quality of life. Just to do that relatively minimal surgical procedure, it's not easy because of those adhesions. And we had to do a quite extended myotomy. Don't stop too early. We all know that from the Hellesser myotomy. Try to cross and go 5 centimeters at least into the chest, and that's what we did, because we were not 100% sure that it was the only narrow segment of the sleeve that has caused it, the resizing of the sleeve. Because also, you know, just at the LES, there was also seemingly on the X-ray some pseudostenotic region. So on that part, we did that quite extensive myotomy.
Nice.
So here we do the dissection of the hiatus, and now we are passing with the gastric tube. Now sometimes you think when you pass with your gastric tube, it's okay, but back again, the patients are not eating an endoscope. With an endoscope, you are pushing. So it's not relevant to make any decision making in just pushing your gastric tube. Functionally, it's completely different. So this is very important that, anyway, you have seen some hesitation when we pass the gastric tube. That's already a bit abnormal by way of speaking. So
Bruno.
Yes.
But why do you call esophageal diverticulum and not hiatal hernia then?
There was a bit hiatal hernia. No, because if you look to the X-ray, if you look to the endoscopy, this is not a hiatal hernia. There was a hiatal hernia, but there is a bit divertical. Probably you're going to see that on the post-op X-ray as well.
But intraoperatively, that is a hiatal hernia to me.
Yeah, there is a bit, you know. Okay, this is regardless, that's 100% true. But this is not what we have seen on the upper GI series. And probably you're going to see that on the X-ray after the surgery as well. You still see a bit that divertical, what I think, or the start of a divertical. If the situation would persist, probably that would even become bigger. But there is indeed also a hiatal hernia, that's true.
So Bruno, when you decided to do this, what are you having on mind? That was just stenosis, and to open as opening a ring will resolve the problem of the patient?
Yeah, because 2 weeks before, there was also another patient transmitted with just the same problems. She got a sleeve, and then she got an omega-loop gastric bypass, and she could not eat, although there was still bile reflux. And we also had to do a myotomy, and also reversing then the omega-loop to a gastric bypass, and she was very good clinic. It was a younger patient. And so, I mean, it's not a real invention, but I think this is the least invasive, best salvage operation in that particular case. You see there the extended myotomy. I'm just willing to show you that case that when you're dealing with revisional surgery, use your brain as well, you know, not just act and think in physical issues, you know, think as an upper GI surgeon more than a bariatric surgeon. So you have to get some experience in upper GI surgery to make good decisions. If the only good decision, I don't know, I just present it to you. And anyway, the clinical result of the patient is very good. That is certainly supporting the decision-making process that we have undertaken. I'm going to show you, I hope I can show you now the X-ray. Can you move or by whatever means that we can see the X-ray? Now it's a far better passage. And the patient is doing better. Now she's weighing 62 kgs. We still have contact with that lady, so now the BMI is going up. You see there, this is rather divertical and not a hiatal hernia. And you see the passage is much smoother. You cannot compare with that before surgery because I could not show that. But this is the This is the clinical case, I think an interesting case.
No plan for the diverticulum?
No, because no. I think the treatment of a myotomy is the treatment of...
So you started the myotomy about 4 or 5 centimeters in the esophagus?
Yeah, but we started at the middle part, because you cannot start higher. You have to go from distal to upwards. But then at a certain moment when I was passing the gastric tube, also at the gastrojejunectomy itself, it was a bit more narrow than normal. So we extended the myotomy up to the gastrojejunectomy. And then proximal, we went 5 centimeters inside the chest.
When you were thinking about the strategy for this case, you have myotomy as plan A. What kind of plan B and C did you have?
Yeah, I didn't have any real plan B. I was really convinced to do that. And it's different. We discussed with Katalin, you know, on barrier link, and a lot of you are going to be invited for that. But the thing is that Katalin has a lot of experience in doing a myotomy for a sleeve, for a torsion of a sleeve, etc. We discussed that. And what he was saying that with a myotomy on a sleeve, at the end, you know, you've got some dilation, motility is going down. We may not expect to see the problems in a gastrojejunectomy because it's a lesser pressure zone. So a myotomy is going to be certainly on terms of function, it's going to be a much better treatment than if you do that for whatever problem of a sleeve. Is that right, Katalin?
In the figure, it's very clear the improvement, no?
Yeah. Yes, indeed, yeah. No, that's just the case. I'm just willing that to trigger everybody when you're going to disembark in revisional surgery, use your brains and also discuss specific issues with colleagues. Is that okay, Almino? I think it's very important before you make your decision-making process.
Thank you so much.
Thank you.
I don't say.
Dr. Bandari.
So,
Mohit, this is not an extreme case. This is a super mega,
case.
hyper extreme case.
So this was one of the patients.
Just use this.
So this was one of the patients we operated. It's a 34-year-old male, weight 410 kgs, BMI 121.1 kgs, known case of morbid obesity, type 2 diabetes, hypertension, OSA, all what you can name for, abdominal wall, bilateral cellulitis, non-healing ulcers, chronic smoker, alcoholic, patient on OH and antihypertensive medicines. Now, for this sort of a case, how many of you would offer a surgery in the very first case, or you would refuse to admit this patient?
If you are leaving the home, you not see the bigger patient in the world. Stay at the home. This is the biggest patient over the world.
So,
yeah, it will come.
So, yeah, I think there's a video there. I can show it to you. But let's discuss about this. How many of you in the hall would actually admit this patient to operate upon, or you would leave him? You'll just go for a medical management and leave it aside. Can we have a raise of hands, please? How many of you would try and operate this patient, or at least admit him to optimize him and then operate? Nobody.
Is working for you?
Yeah.
Is working?
Yeah, it's working. Yeah. So patient had a very tough time, and he flew from a different country, and he had to take a different flight. Domestic flight refused him to take him inside, and then optimized with BiPAP machine, and for a month the patient was there, but then we could try to discharge him, but then again we admitted him after the optimization of another 3 to 4 days. We could take him for a 1 anastomosis gastric bypass. So I can show you on admission, this was the hemoglobin, the TLC count was 9,400, platelet 2.5, these were the electrolytes, bilirubin, albumin, HbA1c, and serum insulin. And post-operative course was eventful. He had an extended ICU stay in the view of his comorbidities of around 20 days. Bypass was continued for a few days, and he was discharged at least a month after his surgery from the hospital. The physiotherapist and nutritionist ensured that he was active and taking adequate post-bariatric diet, and it took 20 days at least for us to put him to the outpatient care. There's a video there. If you want, I can play it.
Let's see the movie. Yeah. Reduce the sound a bit. Too much. This patient is coming from another place in India, Mohit,
So
or
this
from
is the
other
upper
country?
GI endoscopy which we performed, and it was basically uneventful. The problem which we had was, so this is a mini gastric bypass being performed, and 40 minutes was the operating time. Just that was the low-lying anastomosis, and we could extubate him on table, and then we could continue BiPAP for some period of time.
What procedure was?
This is one anastomosis gastric bypass.
And how have you done?
Laparoscopy.
What kind of systematization you use?
Time of surgery, 40 minutes, 35 to 40 minutes. It did not take a lot of time. We just put in the ports. The advantage there was that we need not dissect too close to the G junction. We made a wide pouch and did a 250 to 300 centimeters of anastomosis and came out in 30 minutes. So that was the entire thing.
Congratulations.
Yeah. Oh, sorry.
But it was also very challenging, I think, for anesthesia. For
Yeah,
that anesthesia.
I do not believe in sleeves in super obese, and that would be my controversy with the hall, because when we have done sleeves on super obese, we had a lot of complications. Leaks, superior mesenteric vein thrombosis, pulmonary embolisms. I don't know, for reasons unknown to me, a sleeve gastrectomy causes this entity known as superior mesenteric vein thrombosis and embolism in a very high, they dehydrate the patient too much. And so the first 14 days, we have lost a lot of super obese patients. 250 kgs, we did a sleeve upon, we lost the patient 15th day. So, and 2 or 3 super obese patients in our series had superior mesenteric vein thrombosis, so we restricted here to this. And we have done a couple of super obese, more than 300 kgs with this procedure, so we are quite satisfied.
How long took to prepare this patient?
It took a month's time to prepare the patient.
Oh, at the hospital or
in the hospital? In the hospital, absolutely. It was not an easy thing. We had to put him on diuretics. We have to give him something for his pulmonary artery hypertension to reduce his pressures. We had to do extensive physiotherapy, diet, liver workup, a lot of things.
Okay, thank you, Mohit.
Thank you.
So let's have the final questions. Please, let's vote now. How did you learn about this symposium? Access your application and vote, please. You can vote now. Sales representative, Ethicon booth, Congress program, Congress website, flyer. Let's check, comparing with the patient of Mohit. The patient with the biggest BMI I did was 100 and something, 1 or 2, and you?
And 105 BMI, 105, but not 105 is the max.
Yeah, and this
a male patient.
90.
Torsten?
It's not a very good competition, but
no, it isn't.
No, honestly,
this is the biggest patient you did?
No, the biggest Mufi has operated. I have not done the biggest, but honestly speaking, I was
Can we check the answers, please?
I was trying to refuse this patient, and Dr. Phoebe said that no, you can optimize him and see for a month, but don't be in a haste. You can even have the patient for 2 months in the hospital, and you can refuse him if you feel, but don't be in a haste and just see after a month if we feel it's okay. So the message here is that when these kind of patients come, you need to be prepared to keep them in the hospital pre and post-operatively, at least for a month, 2 months, 3 months, whatever, because operating is not important. More important is to follow them up and make sure that they keep them properly in the hospital. So the budget and the logistics have to be managed.
So evaluate the result of this symposium. Did this symposium meet your expectations? 1, very great stent. 2, great stent. 3, moderate stent, small stent, and not at all. Please vote now. what could be the most important issue, Mohit, in the preparation of a so severe patient like this? For you, which is more important, weight loss, physiotherapy?
No, I think most important is the anesthesia status for these kind of patients. I think surgical part is not that important. The pulmonary artery pressures have to be optimized, the lungs have to be good, the anesthetist has to be confident, and we should be prepared for any post-operative outcome which can happen in these type of patients. So at most times, we deal with them with diuretics and lowering their pulmonary artery pressures, preparing the liver, and decreasing that edema on the abdominal wall so that we can work around well. That's what we concentrate on, not too much of weight loss. I think weight loss will be there if you prepare and optimize them, but it's not the parameter on which you base your
Okay. We have more one. Is the content of the lecture relevant to your daily bariatric practice? The same kind of answers. You can vote now, please. And the surgery, Mohit, if you evaluating a grade of difficulty from 0 to 10, what grade of difficulty you had for doing this surgery?
No, it was
not difficult.
It was not that difficult. I would say it was 8. I would say, but to be honest with you, I have had more difficulties in operating patients of a lesser BMI than this. Sometimes you are in a difficulty. The most heaviest case might not be the most difficult one.
And what kind of pneumoperitoneal pressure do you use in this case?
So we use two big thermoflators, and 20 was the pressure which we kept.
20?
Yeah.
Can we check the answers? Okay. Do you have some more? No. That's for today. 6 to 7, meet the expert in the booth of Johnson. How to communicate and engage with patients referring healthcare professionals. Dr. Kais and Mooney. And 5:45, we have the lunch of the perfect sleep. That is the book. The main author is just here, Dr. Michel Gagné. Thank you for joining us. Thank you, Dr. Thorsten, Dr. Ronald, Dr. Bruno, Dr. Mohit. Thank you for being with us in this Johnson Symposium. And thank you again for Johnson for work of us in continued education in bariatric surgery. Thank you so much.